Welcome to today's webinar, Health History and the COVID-19 Pandemic. This webinar is part of the Center for Global Health's webinar series at the University of Oslo, and that series is called Global Health and the Pandemic. When you, let me say a few technicalities before we dive into the matter that we're going to discuss today. When you registered for this seminar, you agreed that the session would be recorded, and the purpose of that is that we want to make the recording available to those who are not able to join us live, and maybe even, after all, we're historians, keep it for future archival purposes. All participants, the microphones, that's your microphones, will remain silent throughout the session. So when you have questions that you would like to ask, you have to ask those questions into the Q&A that you find at the bottom of your screen. The structure is as such that we will have introductions by the panelists, statements, which will then be followed by discussions first in the smaller group, and then quickly we open up into the questions of the group. On the matter that we're talking about, is there a meaning? Are there different lessons perhaps? The pandemic of COVID-19 that we're all living in has triggered an enormous interest in the history of epidemics and infectious diseases. Such interest is not always subtle, and sometimes it's simply that people refer to gruesome pandemics of the past. But it all serves the interest to establish and somehow comprehend the significance of the event that we're living in. Well, and rather than by just adding more exaggerations to those historical comparisons, today what we would like to do, we would like to go deep. And that's why we've invited 3 professional medical historians to be with us today. We would like to ask questions like, how significant could COVID-19 be and in which histories? Second, we've all grown up in a kind of consciousness that infectious disease is mostly a thing of the past. And even in those parts of the world where that's not the case, it would soon happen in the future. Do we need to rethink our histories of the present with COVID-19 being around us? And finally, global health is something that has a history itself, and this seminar is hosted by a Center for Global Health. Do we need to rethink what we know about the history of global health, how it came about, what the essential traits are? There's no shortage of such questions, and of not shortage of answers given either. And the great historian of medicine, Charles Rosenberg, has once reminded us that in reaction, in interpreting an epidemic, we go through stages from denial through the production of meaning and then finally into resignation. And I do think it's fair to assume that we're very much in the meaning production phase, all of us these days. To discuss these and more questions, I have invited 3 colleagues. Mark Honigbaum from London, Shang-Jen Li from Taipei, and Jean-Paul Gaudier from Paris. And they bring very different expertises to the table, which is the history of infectious disease and the flu, in Mark's case, East Asian history and the history of Chinese medicine in Shang-Jen Li's case, and the history of global health in Jean-Paul's. Our main purpose is to have a dialogue with everybody who is attendant here. And that's why we keep the introductions fairly short. We have 3 statements from our experts, a few questions between us, and then we quickly open up for questions by you. Remind you, you have to write your questions into the questions and answers, and I will pick them up there and put them forward to our panel. And with that, I come to our first speaker, Mark Honigbaum from London. He works at City University London. He's a historian and journalist, and I think it's fair to say that he knows a thing or two about the flu. Mark, the audience is yours.
Well, thank you very much, Christoph, for that lovely introduction, and welcome everyone to this webinar. I think we're going to have a productive discussion. So I'll get straight in. Historians, of course, are experts on the past, but rarely are we also asked to commentate on the future, let alone imagine how we might contribute to a better one. Yet the pandemic of COVID-19 and the crisis it has precipitated in our society and politics has seen a renewed interest in history and the expertise that professional historians can offer. I think this is nowhere more true than for historians of science and medicine, particularly those of us who have been immersed in the study of historical pandemics, such as the 1918 Spanish flu. So I'm repeatedly asked by journalists, among other people, what lessons does the Spanish flu hold for our present COVID moment? How did it and other great historical pandemics, such as the 14th century Black Death, affect society and the economy? Did these pandemics prompt major political changes and psychological shifts? Or were their impacts mainly cultural and felt at the margins? Now, I want to say straight off that on the whole, I think academic historians should resist functionalist readings of the past that seek to draw moral lessons for the present. Most particularly as I found such questions are often motivated by the presentist assumption that because COVID-19 seems to be having such profound social, psychological, and economic impacts today, then the same must have been true in the past. A good example of that is the New York Times columnist Thomas Friedman, who recently referred to COVID-19 as, and I'm quoting, our new historical divide. And he looked forward to the first year AC after Corona. When that will be, however, at present, no one can say. Now, another reason I'm suspicious of this search for continuities with the past is because my studies of the 1918 Spanish flu, the pandemic I know best, suggest it made little impression on the collectivity of society, and its economic and political impacts were also far slighter than one might expect from the scale of the global morbidity and mortality. Hence, its historiographical characterization as the forgotten pandemic. Having said that, I think there are continuities between COVID and past pandemics. Perhaps the most obvious one is the way that, like cholera in the 19th century and yellow fever in the 18th century, COVID has been what the social historian of medicine, Charles Rosenberg, called a stress test, exposing weaknesses in public health systems and social and economic fault lines and fissures. In particular, COVID has reminded us that infectious disease does not fall equally on all members of society. In the United States, for instance, the death rate of African Americans is 4 times that of whites. Why this is so is the subject of urgent inquiry, but the suspicion is that it is connected with inequalities in access to healthcare and the poorer living conditions and higher occupational risks borne by Blacks and other ethnic minorities. As with cholera in the 19th century, COVID has also been a spark for protest and political unrest. I'm thinking of the way that in the early weeks of the American lockdown, right-wing militias invaded the Michigan state capitol in protest at stay-at-home orders, or the demonstrations by health workers concerned at the lack of personal protective equipment and the higher death rates of BAME colleagues, or more recently, the Black Lives Matter protests born in part out of the aforementioned health inequalities. Whether we will see major structural and economic changes as a result of COVID-19, I think is less certain. One of the lessons of medical history is that such changes usually occur only when a pandemic has major demographic impacts, as was the case with plague and the transformation of feudal relations in the 14th century. This may be why the Spanish flu did not result in significant social or political change. The pandemic killed in excess of 50 million people worldwide, but the case fatality rate was around 2%, which is similar to COVID, and left most of the population unaffected. Nor, despite depressing GDP by 5%, did the Spanish flu precipitate a major economic depression. On the contrary, after the pandemic, the economy rapidly returned to its pre-existing steady state. Having said that, one of the fascinating things about COVID for me is the way that it has forced me to question what I thought I knew about 1918 and re-engage with primary sources. For instance, even before COVID struck, scholarship was mounting that far from being a democratic killer, Spanish flu affected some communities and social groups worse than others. That scholarship has now become even more relevant and urgent. COVID-19 has also challenged our assumptions about the management of pandemics in the 21st century. For instance, when in January, China announced it was quarantining Wuhan, a city of 11 million, many historians and epidemiologists expressed skepticism, pointing out that never before had quarantines been enacted on such a scale. But within days, the restrictions have been extended to scores of other Chinese cities, placing 33 million people under lockdown. Perhaps skepticism about the possibility of copying China's experiment explains the initial reluctance of Britain and other European countries to recommend social distancing and home isolation for their own populations. But here we are, 6 months into the pandemic, and from London to Paris and Stockholm to Oslo, social distancing has become the norm, and the test, trace, and isolate methods pioneered by Southeast Asian countries are now seen as a model for other nations. Once again, I've been reminded of the example of 1918 and of cities such as St. Louis, where officials banned public gatherings early on in the pandemic and succeeded in flattening the curve. By contrast, cities such as Philadelphia, that allowed Liberty Loan parades and other gatherings to go ahead, suffered much higher mortality and worse economic impacts too. So I basically want to leave it there. Very quickly, though, I think I wanted to mention this theme that I put in my abstract of the pandemic imagination. And I want to really ask what accounts for this political failure to imagine interventions like China's, and to what extent historians are guilty of similarly constrained thinking to politicians. So COVID-19 has been described as a wake-up call for the world. But what is it that medical historians need to wake up to? What is it that we failed to pay sufficient heed to? One answer, I think, lies in following an example of an earlier generation of medical historians. So I'm thinking in particular of the founding fathers of the discipline, such as Edwin Akkerknecht, Henry Sigerist, and Oswald Temkin, scholars who saw disease as both a biological phenomenon, older than recorded history, and one which also could not be understood apart from its clinical manifestations and its medical and cultural framings. It was an approach that was not afraid to engage with longue durée historical perspectives, and which actively sought to integrate medical history with insights from geography and biology. And also it was an approach that emphasized the importance of social relations and the way in which ideas of contagion and contamination have often been instrumentalized for political ends. So with that, I think I'll end it and hand over to our next speaker to make a statement. Thank you very much.
Thank you for a very engaging introduction, Mark, and I'll now hand over to Shangjian Li. And Shangjian works at the Academia Sinica, which is a National Academy of Sciences in Taipei in Taiwan. And Shangjian Li, the audience is yours.
Thank you. In this brief introduction, I would like to reflect on the importance of recent history, not just medical history, but also political history. And I argue that the source and an understanding of the political culture of China are crucial in shaping Taiwan's initial response to COVID-19. Taiwan has been widely praised for early response to the pandemic. So far, the country with a population around 24 million has only 425 cases and 7 deaths. There has been no locally occurred infection in Taiwan for the last 64 days. Although during this period, there are some imported cases. Considering the geographical proximity of Taiwan to China and the close economic tie, the result is all the more remarkable. The distance between Taiwan and China is only 130 kilometers, and there are 500,000 Taiwanese citizens living and working in China. Before the pandemic, every week there are about 10,000 passengers traveling between the two countries. And last year, there are around 3 million Chinese citizens visiting Taiwan. And Taiwan's containment of COVID-19 is attributed to its government's early response. It took action earlier than most of other countries. For example, on December 31 last year, the government staff announced a major boarding the audit flight from Wuhan by medical inspector to check on the passenger before they can disembark. And Taiwan's swift response stemmed from a particular reading of the opaque situation in Wuhan in the early stage of the outbreak. The deputy director of Taiwan CDC later claimed that their action was prompted by a leaked copy of an emergency circular issued by the health board of Wuhan City. A copy of that document was posted on the social media in Taiwan. And that media is basically for political gossip, sometimes fake news, but also leak. And they took it very seriously. They immediately initiated the measure. So why Taiwan took an unverified leaked document so seriously? The main reason underlying Taiwanese government's response is a deep mistrust of Chinese official information, partly due to long political antagonism, but also partly due to the experience of SARS in 2003. At that time, the Chinese government covered up the outbreak for several months before admitting it. And during the epidemic, Taiwan had 346 cases and 37 deaths. The numbers doesn't sound big, very large, but the impact is huge. The largest cluster infection occurred in a public hospital in Taipei. It went into lockdown in an ill-prepared manner. Within 2 weeks, 97 hospital staff and 23 patients died of SARS, and 1 patient committed suicide. The haunting images of medical staff calling out for help from the hospital window was broadcasted repeatedly. It created an atmosphere of fear, panic, and chaos at that time. The stock market and real estate price fell drastically. Since the SARS pandemic, Taiwanese government and society in general have been worried of infectious disease emerged from China, and often held a skeptical attitude toward their official information. Awareness of the accuracy of Chinese government information with regard to early stage of this pandemic can clearly be seen in an interview by the Telegraph, an English newspaper, of Dr. Zhuang Yinqing, a Taiwan CDC infectious specialist, about his and his colleagues' fact-finding trip to Wuhan in mid-January. And I highly recommend it. Any historian who wants to work on the early history of this pandemic should look at that interview. It revealed a lot about the things in Wuhan. According to Dr. Zhuang, in a meeting where the experts from Hong Kong and Macau were also present, Wuhan's health official and medic divulged little useful information, and speaking only about the treatment of the patient menace. They covered little information about the kind of spread of disease, whether it can transmit it from human to human. And actually, one health official denied the possibility of human-to-human transmission, but he was rebuffed by a central government official from Beijing who said that don't give the kind of dated information. Now, the possibility of human-to-human transmission cannot be excluded. And I quote from Dr. Zhuang's interview, quote, "This is a real bad situation. That is not easy for them to admit a limited human-to-human transmission. For me, there was absolute human-to-human transmission. After the meeting, the host offered to take those guests to sightseeing, but Dr. Zhuang and his colleague declined. They stayed in the hotel and took the early flight back because they think the situation outside is very bad. They don't want to risk themselves of infection." So Taiwan's response is based on a particular reading of this kind of small detail and information from Chinese official and leaked documents. And that's based on a kind of a kind of political understanding of the political culture there, but also past experience. So if we want to understand the early stage of the pandemic, I think we need to pay attention to this kind of, historians need to pay attention to this local culture and how people talk, how people decipher the information. And one problem of the SARS outbreak that I mentioned was the political wrangling between central and local government in Taiwan. At the time, the mayor of Taipei and the president belonged to different parties. So they have short response. So after that, Taiwan created a central command to cope with this emergency. And they revised the contagious disease law, like endow the command center a lot of power. So they can respond very quickly. So after the outbreak, they rapidly restrict the travel between Taiwan and China, screen the passenger from China, and install quarantine of all the Taiwanese citizens from coming back from China, and basically ban the kind of Chinese citizen entering Taiwan. And so they also have the emphasis is not on what we saw in, for example, like in the UK about computerized epidemiological modeling, but instead it's kind of old-fashioned case tracing, isolation, and testing. But it's not a kind of large-scale testing like you've seen in Korea and China, but very targeted, limited testing based upon case tracing and contact tracing and the case history. So they spend a lot of effort on that, although they use some new technique. For example, every Taiwanese citizen have a kind of healthcare card like this with a chip on it. And so they connect a database of healthcare with immigration control. So the medical doctor knows the travel history of the patient seeking help. And so they're alerted to the risk, whether the patient may be infected by COVID-19, because the differential diagnosis is very difficult between COVID-19 and other respiratory disease. And they also use kind of electronic tracing, like everyone under quarantine, they will issue a mobile phone, or if they consent, their mobile phone will be kind of traced and located. And there was social service provide support, but also checking on the people being quarantined. And there are heavy penalty for quarantine breaking. And police treat it as a major offense. And so basically, the success is based upon the kind of infrastructure of public health, but kind of rigorous enforcement of this kind of quarantine measure in case tracing. And finally, an important factor is a large proportion of population are also alerted to the risk of COVID-19. And that is also because of the experience of SARS. So when Wuhan was when Wuhan came into lockdown, in Taiwan, people put on face masks. The government requisited the production of face mask and mandated, but before they mandated wearing a face mask in public space, people already kind of putting face masks on. And in a restaurant, bar, any sort of establishment, including my institute, you have to have your temperature taken before you can be admitted. And there are hand sanitizer everywhere. They spray your hand before they let you enter a restaurant or a bar or movie theater. And so, for example, in Taiwan, there are 10 cases like the source of infection could not be traced. However, the infection did not spread out. It poses a great risk, but infection did not spread out. It just petered out. So I think one of the important factors is kind of hygienic practice of a large part of the population that help contain the spread of the disease. And so to conclude my introduction, I think in the near future, we should conduct some research on the measure adopted by different countries, because we can see that actually the basic information about this disease, once the pathogen and its effectiveness were ascertained, we all have a basic understanding of it's coronavirus, it's highly contagious, it's spread by, its way of spread is also very clear. Unlike in the 19th century, there are a lot of debate about mode of transmission or even the cause of the disease. However, different countries' response are very different. And I think they are all shaped by kind of local history, the particular history of that country as they have experienced a recent kind of pandemic, but also their political history. And I think we should do something like, for example, like mid-war study, a comparative study of sleeping sickness in Africa in the early 20th century, where a different country, although they have same basic understanding of the disease, but they have a very different preventive measure. I guess if we're doing on a large scale, and we can have a better history of this pandemic. Thank you.
Thank you very much, Zhang Zhen, for a story that took us deep into the politics of fighting epidemics. And with that, I give to our third introductory speaker, Jean-Paul Gaudier, who is a historian from France, and he works at the French National Institutes for Medical Research, the INSERM, and he's also a professor at the EHESS. And I think he's going to be speaking somehow about global health, if I'm not mistaken. Jean-Paul.
Thank you. So can you tell me if you see my screen? Not yet.
No, I don't see it anymore.
Okay, so I'll try again.
It was there for a little moment.
Yeah.
Now it's back.
It's back? Good. Okay. Here we are. Thank you. So, 4 years, health interventions worldwide have been associated with the idea of global health. And the term has multiple meanings, but one thing is clear: it was barely used before the 1990s. So the global has somehow superseded the international. And we have a historical scenario to interpret this rise of global health. It is the narrative historians such as Marcus Cueto and Emmanuel Byrne or Randall Packard have elaborated. It links global health and the neoliberal turn that started in the 1980s. And to put it in a nutshell, global health is accordingly challenged the form of social medicine associated with WHO, the primary healthcare strategy, and the mere idea of a right to health for all nation states should implement. So global health brought back to the fore vertical programs focusing on one disease, mobilizing one or a few technological tools, and controlled by those financing them. This scenario has a lot to it, even if it postulates a kind of revolutionary break with the post-war past, a kind of radical departure with international health that doesn't stand close scrutiny. But indeed, if one tries to characterize the main traits or the main features of global health as it operates since the transition decade of the 1990s, I think one needs to look at its defining triad of actors, targets, and tools. So these, on this slide, are data on the level of financing coming from the Institute for Health Metrics and Evaluation, a joint venture of the University of Washington and the Gates Foundation, which is one of the leading research centers in global health and coordinates the production of the famous Global Burden of Disease databases. And the figure does not only show the massive increase of funding in the 1990s, 2000, it also reveals important changes like the health turn of the World Bank, the new role of philanthropy beginning with the Gates Foundation itself, or the decline of French bilateral aid in contrast to the US pattern. IHME experts also look at the targets of these investments. And here we have major evidence of the continuity with post-war international health. Although the global health literature has continuously stressed the importance of a new epidemiological transition, namely the fact that the so-called low and middle income countries face a double burden. This means that they are affected both by the continued presence of infectious disease and an escalating impact of chronic non-communicable diseases as a consequence of industrialization, urbanization, and changing mode of life. And yet, global health just targets the former. Mental health, cardiovascular disorder, cancer, I mean, the whole palette of chronic non-communicable diseases barely count for 3 to 5% of the financing of the investment in global health. The gap is absolutely enormous. Finally, global health tools, like its preferred metrics, reflect a process of economization of health many observers have noted. From its early days, the famous calculus of Daly's, which has played a paramount role in making visible the impact of non-communicable diseases I was mentioning, this calculus has been associated with attempts at advancing a combination of economic and medical evaluation. I want to remind you that the first systematic use of Daly's in the report entitled Investing in Health, the World Bank published in 1993, this calculus was, as this figure shows, linked to cost effectiveness analyses leading to the ranking of health intervention through the calculus of how many dollars do one specific intervention require to save one Daly. And the dream was then to use such data to be able to define sustainable, reasonable health packages of interventions. All this is about what I would call the global health field. It is, however, important not to forget that the field is not all, that the ways in which health has globalized in the past 3 decades is not reducible to what happens on the self-defined global health scene. And for instance, the traditional medicines from Asia, Ayurveda as well as Chinese traditional medicine, are circulating globally without any connection or very few connections with the operation of the field and the self-identified global health factors. And you might also have noted in the first slide I presented that in IHME data on financing, among the donors, Chinese aid was not counted. So finally, what would address the main question of for this our discussion? What can our historical knowledge of the transition from international to global say about the COVID crisis? The argument I like to discuss is that COVID-19 challenges global health in so many ways that can be thought of as a threat, which could seriously destabilize the field. And I want to mention 4 reasons for that. They all must be considered as heuristic claims deserving further discussion. They are certainly not statements of facts. But the first one is that up to now, global health factors have barely been visible in the response to the COVID-19 pandemic, with one exception, which is WHO. Paradoxically, precisely the institution that leaders in global health have looked at with great suspicion and pressed for reorganization since the 1980s. In contrast, nation states and public health administration dominate, with one remarkable exception again, the deafening absence of the United States federal state. Second, economic performance has been put into bracket, at least in terms of selecting health interventions. In other words, what we are facing in terms of prioritization and triage is the return to a very political way of allocating resources, with the almost absence of the kind of cost effectiveness calculus I mentioned before. Third, the favored tools of global health, vaccine and drugs, are not there. Hospital care and social medicine in the form of lockdown or in the form of the test, trace, isolate strategy dominate. As a consequence, what I think is the ghost hunting of all global health programs, I mean public health infrastructure, their nature and operation, or their lack of, are central to understand the dynamics of the pandemic, whether it is to understand the scarcity of materials affecting many countries in Europe, like France, Italy, or UK, or the relatively successful cluster management we saw in East Asia. And fourth and finally, all this challenges, I think, two fundamental predicaments of global health as a field. I mean, on the one hand, the divide between wealthy industrial societies recognizing health as something accessible to the majority of the population and the rest of the world, condemned to scarcity and systematic triage. And second predicament challenged, the idea that expertise is in the global north, while pressing health problems are in the global south. The pandemic thus strongly calls a rethinking of the governance of health on a global scale, I would argue. Thank you.
Thank you very much for taking us to the field of global health. And we'll now go into a round of discussion between the panelists. And I would maybe like to kick that off by a question which is in a sense something that comes to me by listening to all of your three presentations, and that is there seems to be an interesting difference between reactions to the flu in 1918 and reactions to COVID these days, and that is that when I read reports about the 1918 flu, people often complain that traditional hygienic measures like quarantines, for example, failed. In the reactions to in the current situation, however, the technology that we're using in meeting the challenge seems to be a recourse to very traditional measures of public health. And I think that's also something that Shang Zhen very much emphasized about the Taiwanese answer. So it's washing your hands, social distancing, quarantine, things have been invented between the 14th and the 18th century, basically. And obviously the toolbox of global health is nowhere really to be seen. So what are your ideas on that?
So can I just very quickly say something about this and then hand over? I mean, first of all, I thought both the presentations were excellent. They made me think about a lot of the themes that have also occurred to me. But just to answer specifically, I think the example of the 1918 influenza has dominated global health planning around pandemics. That's absolutely clear. Definitely since 1997, when we saw the first outbreak in Hong Kong of avian influenza. And then in the early 2000s, when there were outbreaks across Southeast Asia, all the planning and predictions were that the fear was that, that H5N1 or some other avian influenza would spark the pandemic. And it's striking that all the pandemic plans, and indeed the models, the epidemiological models used by Imperial and other disease modelers, were predicated on the example of influenza, and in particular the idea that 1918 served as a model for a worst case scenario. And I think that this actually ended up misleading and obscuring the many ways in which the coronavirus is not influenza, and the many ways in which it, unlike influenza, does lend itself to tried and tested public health measures, such as social distancing, home isolation, and most particularly testing, tracing, and tracking, right? So I think, so just speaking as a historian rather than from the perspective of epidemiology and public health, I remember very clearly in the beginnings seeing these pictures come out of China. And it was confusing, as Shang Zhen points out. There was a lot of distrust of China, and it wasn't clear what these images or reports were telling us. Could we, in other words, believe it? So even what I was trying to get to is, I think that in a way, this is a failure mainly of politicians, to imagine pandemics on this scale and responses of the type we're seeing. But I think it's also a failure on the part of historians to, you know, imagine how pandemics in the future are not like pandemics in the past, essentially. So, you know, no two pandemics are alike. They're all different and they're unique in different ways. Mm. So there were similarities with influenza and Spanish flu, but there are also so many differences that those comparisons can mislead as well as inform.
We tend to be complacent not to talk about the future as historians, but that complacency has certainly been checked. Jean-Paul, you stuck up your finger.
Yeah, I was just want to, I would like to have you, Mark, say just one word about the military context and the ways in which it has hinged on the visibility and the political and the tackling of the pandemic.
The military context.
Yeah, I mean that I've often heard that for instance, in the French case, the fact that the pandemic was happening right at the end of the First World War, made it extremely easy to overcome and to turn that into a kind of quasi-marginal event.
Yeah, well, I mean, yes, I mean, this is, a central part of the history is that because the pandemic coincided with World War I, and the war had all the most compelling narrative lines. So, I mean, one thing we didn't see in 1918, which by contrast we have seen a lot, is you didn't have chief scientific officers or medical officers of health giving televised news conferences and saying, you know, here's the R0. People weren't given the specific information that there was this pandemic. So if you weren't affected, if you didn't know someone who was ill or hadn't lost someone to Spanish flu, you may have not really registered that this massive pandemic was occurring. And if you take away the media and everything else. So yeah, I think that's true. By contrast, and coming back to your theme about global health, you know, even before the World Health Organization is established in 1947, 48, it's the military, and specifically the US military, that make influenza an object of research and concern, precisely because they realized the impact it had on hospitalization of troops in World War I. And they were keen to avoid that in World War II. And that's when you can see the beginning of this massive global effort, really, to prepare for influenza pandemics by sourcing new viruses and sharing that data through vaccine reporting laboratory centers. So yeah, so that's been a theme that runs all through global health to the present day. Yeah.
Chang-Jen, is something you would like to add to this? Or
I think the kind of what you say about a kind of old method adapted, but they adapted in a very kind of a sort of new way, using new technology, and also based on, in Taiwan's case, they also based on the previous experience of SARS, which is also a coronavirus disease. So I think this experience is very important in shaping the response. And those who are in charge in sort of the kind of preventive measure at the command center are mainly infectious disease experts. They are medical doctors, not epidemiologists. That's the kind of difference, I think. And so they had an experience of a kind of hospital infection during the previous kind of coronavirus outbreak, and I think that experience is quite important.
Yeah. We're beginning to see that you know, what we call a pandemic is actually, I think it was mostly Chang-Jen who reminded us of that, is actually many locally different epidemics. I would still like us to probably reflect a moment on the possible consequences for what we can call the geopolitics of global health. So who's going to rule the political scene in this situation and in the near future? And it strikes me that Chang-Jen, you've opened the perspective on a it was a bit gloomy to me, because on the one hand, the Taiwanese approach was based on a skillful mistrust of Chinese politics. But when we think of what Jean-Paul said, it is not unlikely that actually the influence of mainland Chinese politics in global health is going to become very strong as a result of this. So what do you think could be a strategy for Taiwan to maneuver in a situation where the mistrust has paid off, but is ever more justified, so to say? And I would also like the others to talk maybe a bit about the geopolitics of global health and whatever it is. Yes, please.
I mean, the mistrust is about their official information, but they are communication between medical professionals. And that's an interesting thing. The things being linked to Taiwan. For example, immediately after Wuhan lockdown, I have a dinner with a physician friend in Taiwan, and he showed me a photo, and that's a Wuhan doctor, kind of secretly taking photo of the kind of hospital infection kind of record, and send it to his Taiwanese counterpart. And my Taiwanese kind of medical friend, my Taiwanese friend who is a doctor, he said, "Oh, look at this. The situation is really bad there. It's serious. So many hospital staff got infected. The deputy director of the hospital died. A professor of medicine died. So it's very serious." Yeah. And so they do know the situation. So it's not like gloomy. I mean, there are some political obstacles, but you need to build another channel of communication, maybe sort of between medical profession in a kind of more private channel to sort of deal with this kind of situation. And I also like to say that, and because we don't know that the U.S. threatened to kind of withdraw from the WHO, and WHO was kind of put into a very difficult situation this time between the kind of CCP and Donald Trump, kind of between the devil and the diplomacy, and it's impossible situation. And but in the case of Taiwan, we had been isolated from this international organization for a very long time, and so we have a sense of kind of risk and crisis. So we have a sense that we need to be well prepared, because if we failed, maybe nobody will come to our aid. Right. And so after SARS, they reformed the kind of command center of emergency, and they built a lot of isolation ward, etc. And so it's kind of preparedness, and this can be related, for example, the financial crisis, Asian financial crisis in late 90s. Because at the time, like Hong Kong, Thailand, Malaysia, they are all badly kind of hit by the financial crisis. But Taiwan emerged relatively all right, because we have a very strong regulation on the financial sector. And that is also based on kind of sense of risk. Like if we failed, IMF is not coming to rescue us because we are not a member of IMF or World Bank. And so there's a sense of kind of risk and isolation. And in this case, in a kind of paradoxical way, it helped us to deal with this pandemic.
Yeah. Thank you very much. Any comments from Jean-Paul and Mark?
Yeah, well, maybe two things on the way you put it. I mean, the geopolitics and how the events we have been facing the past 6 months might influence it also. I mean, one of the reason why in our analysis of global health, we have insisted on the difference between the field, as I presented it, and the processes of health globalization, has precisely to do with this geopolitics. I mean that if you look at the field and at the main institution and actors of global health, you, in terms of geopolitics, you see something which is quite clearly dominated by northern centers, northern expertise, I mean the northern abilities to finance health intervention. But if you take into account more broadly all aspects of circulations, of products, of tools, of personnel, of money involved in health globalization at large, then there is a massive soft system of relationship, and which is barely visible in global health as a field. And one strong element in this South-South set of relationship and influences has to do with China and the way mainland China has been investing in health as a strategic geopolitical tool. I mean, we have one colleague who has started to work on the construction, the building of hospitals in Africa. And in the last decade, you can see that the most new hospitals in sub-Saharan Africa, especially West Africa, have been built with Chinese aid and Chinese investment. So this is just an example. It's part of the decisive trend and pattern which make a big difference with the international health as it existed in the 1960s. I mean, at least in terms of scale. And the second thing I want to put on the table has to do with the impact of the COVID-19 pandemic, is that there is a new pattern of circulation or a new pattern of strategic relation that is now beginning to take a new importance in terms of circulation from the south to the north. And we have seen that to a large extent with the question of where do European countries facing the epidemics have been looking for in terms of materials, in terms of masks, in terms of equipment, in terms of tests and so forth, and but also in terms of donation. And this is also something that is barely accounted for or taken into account in the classical global health we've seen in the 1990s to 2000. So this leaves us with a major geopolitical question, which is about the role of WHO and how this is going to reflect the future of WHO.
I'm looking a bit at questions that are rolling in the questions and answers, and some of them relate very much to what we've just spoken about. And I'm picking up a question here from. And I'm pressing Zhang Zhen a bit further on the points he just made. And so, and I'm referring to a question that's asked by my colleague Heidi Fjell from Oslo. And that is, so what could we imagine to be the international role of Taiwan as a global health actor? Because, you know, everybody's referring to countries like Taiwan and South Korea. This is where you find inspiration. But if I follow what you just said, it's not going to be very easy to be inspired because the political scene is a bit locked.
Yeah, the kind of model seems very difficult to replicate. Mm-hmm. But I think that it's a pity that Taiwan could not participate, for example, like World Health Assembly. We used to be able to participate as an observer, but now it's being blocked by China because of due to the kind of political situation, recent political tension. But I do think like a kind of broad participation of institutions such as WHO is still very important. It's important for exchange of information and experience, and so I can only hope that the situation can improve.
Yeah. I have several questions here from people in the audience, and they all somehow relate to the question: is this a situation where what we call pandemic preparedness has been justified, or has it been disproven? And I think we can maybe start with you, Mark, on that. So is it because as you said, pandemic preparedness had been so much inspired by the historical example of the Spanish flu and by a couple of more things, but do we see this as a situation where we actually think that pandemic preparedness has paid off, or would we more think, you know, in those places where it worked, actually something else worked rather than pandemic preparedness?
Well, I mean, the first thing I'll say is that pandemic preparedness does not preclude the public health measures that have appeared to have worked. that's the first thing I'd say about that. But yes, and I think this goes to the issue of global health and what is who are the institutions. So who are the institutions? Who are the people that were actively looking at pathogens that might pose pandemic threats and trying to prioritize research into them? They were the World Health Organization, who in 2018 added a new disease category to the International Health Regulations priority list. And that category was called Disease X, okay? And that was out of recognition that the next pandemic might be caused by a virus that nobody had yet typed or identified. By the way, they also had SARS and MERS coronaviruses on that list. But we now know that this coronavirus is sufficiently different to SARS and other bat-derived viruses that it did indeed constitute a disease X. Who else was trying to warn and prepare the world? Well, I'm afraid it was people like Bill Gates. You know, so precisely these actors who are often treated with suspicion, not just by China, but I'm afraid by academics who have kind of made an industry the last 10 years of unpicking the narratives and discourses of global health security because of suspicion that they really serve a military or the commercial interests of Western pharmaceutical countries, all of which might be true, but doesn't preclude the fact that this is important because, as we've seen, pandemics, when they do erupt, pose a threat to everyone, not just the wealthy North. Okay. So yeah, I think it's important. But the point I was trying to make is that we also have to guard ourselves against what we think we know based on our past knowledge. And this is where historians can come in and help, I think, because you'll know this, Christoph, as someone who's made a career out of studying laboratory medicine. You know, our knowledge and understanding of the pathogens is very much constrained by the laboratory tools that we have available at any one time. And in the case of pathogens, you know, we can only know as much as the viruses we've actually been able to isolate and type and study in using, you know, today molecular genomic techniques, right? What I would sort of direct ourselves to is who was it that was actually going out into caves and remote animal habitats in China? It was Western scientists, you know, disease ecologists from America and other European countries, but working closely with their Chinese colleagues at the Wuhan Institute of Virology. And often these scientists, of course, they're having to sort of leverage funds from the National Institutes of Health in the United States, or, you know, governments or the World Bank, people like this, but they're also working in their own networks. And I think these networks have been very, very important in sharing information and helping us prepare better.
Okay. Thank you. I see that Jean-Paul wants to say something, but I would like to add a question from the questions and answers to that. And that is, you've made the point that WHO and global health is probably going to be weakened as a result of the political situation that we currently have. There is a comment to that from Klaus Kirchhoff from Dublin, who saying that, well, maybe we shouldn't be too myopic in just looking at WHO. We can see that, for instance, the Gates Foundation has gone big in funding vaccine work currently, working with the CEPI and other institutions, and so there is maybe a case to be made for global health being not quite as seriously affected as you maintain. So that was a question from the audience.
Yeah, that's an important question, and I certainly don't want to make any kind of absolute definite sure statement here. It is also a matter of how the process is going to evolve, and true if we compare the recent weeks with the beginning of the pandemic. It's not exactly the same situation. I mean, the Gates, but also the World Bank, for instance, have taken some new initiatives. I mean, the Gates in relation to the vaccine, the World Bank in terms of loans for the most affected countries. But there are interesting differences here, and they have to do with the basic predicaments or the grounding assumption of global health and how they are or not displaced by the COVID pandemic. I mean that in a sense, what the Gates is doing is very much in line with the ways in which the foundation has understood global health. I mean, vaccine has one of the major tools to intervene. Investment in research and technology development, and opening the debate about the ways in which these technological tools can be made affordable, available. The World Bank, we see something slightly different in the sense that the loans associated with the COVID-19 pandemics are all focusing on health systems and the reinforcement of health system as such, which is has been a matter of tensions for quite a long time between the World Bank as a development institution and the program, the vertical program oriented preference of global health as a field. So it's a moving situation, but the fact that there are a series of challenges opened by the new situation is, at least that would be the hypothesis I would work on. Now I wanted to come back for a second to the question of preparedness, because it's also, I think, a nice illustration of the ways in which the pandemic is reopening a series of issues. I mean, on the one hand, you can say that the pandemic is confirming a certain insistence biosecurity people have put on the idea of preparedness, and a certain emphasis on the tools which were associated with biosecurity, the models, the question of the vaccine, of making certain stocks in advance in order to face an emergency, and so far so forth. At the same time, the COVID-19 is challenging that, and because what preparedness is less a matter of, appears less a matter of technical advancement or research, has a question of public health apparatuses and public health infrastructure. And here, I just want to mention, because I can't avoid it, the question of shortages or scarcity, the way it has been lived in France. I mean, one of the basic missing protective tools were the masks, which is far from high-tech material, and it's really basic public health tools in a very old-fashioned classical way. And the shortages in the countries have been traced to two features or two elements. One is the industrial globalization, whose consequence has been that the textile industry in the country has become extremely weak. And the second feature is a lack of preparedness, in the sense that having stocks of masks has been considered too costly. And after the H1N1 epidemic, they were destroyed. So that's where the question of preparedness is not necessarily as high-tech oriented than the whole discussion 15 years suggests.
Yeah. Thank you. I would like to refer to the panelists a question that is asked by James Young, and it firstly it goes to Mark, but then it goes to all of us, and that is, Mark mentioned that the current situation made him reassess some of his old sources, and I can for myself confirm that, being a historian of medical microbiology, I tried the same, and I realized that my sources were mostly inappropriate, because I'd been working on medical microbiology, and epidemiology, which is so important these days, has mostly escaped my interest. So would probably would like to hear from the three of you. Have you been, if you went back to sources, which sources were those, and did you find them meaningful? Maybe we'll start with you, Mark, because you kind of did that. We know that.
Well, I mean, so this started for me when I first saw those extraordinary images from Wuhan of the Chinese constructing these hospitals and these huge waiting rooms overnight, okay? You know, so these vast waiting rooms full of bunks and cubicles for the patients. So that reminded me, nothing so much as perhaps the most famous picture from 1918, which was taken in Camp Funston in Kansas, which shows these soldiers at the Camp Funston Army base in this vast auditorium, all laid out on bunks. It's the most famous picture, and it's usually associated with the American origin story, the idea that the pandemic started in Kansas and spread from there to Europe. So, I mean, that picture is extremely problematic for all sorts of reasons. There are lots of other theories about where the pandemic started. But what I found interesting about that picture is I said, well, you know, that made me think, are we seeing something similar? And, you know, is this picture that I thought was misleading actually maybe an accurate reflection of what pandemics look like in their early stages? So that's the first thing. But more importantly, you know, because 1918 was so different, we didn't have overt public health messaging, and we didn't have a press or a media actively amplifying those messages. What you're left with is really the primary sources, so letters or diaries or accounts that individuals have written. And one of the things that I find myself returning to again and again were the accounts by doctors and nurses who witnessed and were on influenza wards when this terrible respiratory pathogen hit. And what they described was so similar to what we were seeing in London at the time, with hospitals being overwhelmed. So I thought that had particular lessons, and those are the sort of the sources that really spoke to the present day very, very powerfully. But more broadly, because COVID-19 has brought up this issue of the way that social distancing is causing these massive economic impacts. And a lot of the questions I were getting from journalists were, well, didn't that happen in 1918? And I said, well, that's interesting. So very few scholars had actually bothered to really look at the economic impacts of 1918. And there are very few papers on this to this day. And the problem is that the data, the economic data, there isn't very good economic primary data. So it's quite hard to you can see in some areas of the world or some cities, it does have a big bad impact, but in other places, it seems to have very little impact at all. So those are the sort of things, the questions from the present that caused me to go back and ask new questions about, you know, 1918.
Maybe for the other two, you would like to add something that you went back to and that appeared in a new light?
Yeah. If I want to study COVID-19, the history of COVID-19 or other recent pandemic, I guess I will rely more on oral history and interview a person and try to question them. Because in this pandemic, and I talk to doctors, and sometimes I talk to doctors, etc. Sometimes they complain about the official information. It's kind of spinning. Right. They're spin doctoring. Because during the crisis, it's important to control information because you want to make the kind of public behave in a certain way. And we see, for example, in the UK case, like Dominic Cummings is in the Sage, and when this was found out, it caused a kind of minor uproar in the kind of liberal press, and I guess it's everywhere. Like they want to sort of messaging the public, and so if I and also I mentioned a case that how Taiwanese infectious disease expert tease out information from the Chinese counterpart. It's not from official kind of statement or document, but it's through other kind of interaction that quite very implicit and so kind of texting, almost like a texting analogy, how you tease out information from a conversation, etc. So I guess it's quite important to understand what was going on by interviewing these actors.
Well, okay, well, then Jean-Paul, you wanted to add something here? Something?
Yeah, maybe, I mean, well, it's less in terms of having actually started to look at my archives and existing material, but in terms of displacing questions or issues and an emerging future agenda. And I just want to mention two examples here. I mean, one is about the situation in India, because the collective work we were doing on global health India was one of the target countries. And there you have a very contrasted situation depending on which state you're looking at. So that you have catastrophic situation in some of the northern states in India, and an epidemic which seems to be still under control in a state like Kerala in the south of India. And one interpretation our colleagues there suggest for explaining this contrast and the local control has a lot to do with the mobilization of local public, primary health institution and the mobilization of the communities. So that it's part of the local handling of clusters and combination of public health and social measure, for instance, the question of providing food to the people who are placed under isolation or quarantine. And this brings in an interesting historical question about the status of actually primary healthcare and the history of primary healthcare in that state, which seems to be fairly different from the rest of India. And it's one an interesting dimension that can be reinforced by the pandemic. And the second example is more on the French line. I mean, one of the things we've somehow neglected in the work we have been doing on global health is the question of clinical triage. I mean, the triaging of patients for access to specific means of care or specific therapeutic intervention. And we neglected that because we thought, oh, anthropologists have been writing a lot about clinical triage. It has been part of all the literature on humanitarian intervention and so forth. And what we've experienced in France and in European countries is the new strategic role of this clinical triage. For instance, for access to emergency services. And it's somehow a new frontier that could be important for, in historical terms, which is to trace the ways in which clinical triage has existed in the past 20, 30, 40 years in hospitals of the North, and not solely in the classical scarcity-based oriented situation of southern countries and southern hospitals.
What you seem to suggest brings me to pick up another question from the questions and answers, and that is a question that is asked by Adidamola Aditiba, and she is asking about the position of African states in the global efforts. It's not something that we probably find very easy to comment on currently as historians, but it strikes me that in your answer to the question before, there is something here, Jean-Paul, and that is that we can interpret COVID as a situation of global health coming home. So something that we thought was reserved for the military and global health, which is operating under scarcity, austerity, making triage choices, is now becoming a situation that for instance, seems to have been the case in some parts of Italy. Maybe one of the panelists would like to comment on that. So what do we think about the African situation, and is it becoming more meaningful for us? Mark and Xiangjin, you will have to answer to that because Jean-Paul has just vanished.
Sorry, could you just repeat the question, Christoph? I was typing an answer.
The question is, the question that we were asked was if we could assess the position of African states in the global efforts against COVID-19. And does it help us to rethink the history of global health governance on the reaction of African states, will that help us to rethink global health governance to some extent?
Yeah, this is a difficult one for me because you're a little bit beyond my expertise, but I do think there is one way in which, so I forget, but there were some African countries that mounted a very effective public health response and did employ contact tracers in a way that we still seem to be unable to do in my own country, the United Kingdom. So I'm not an expert on this, but I suspect that a lot of this may have to do with the fact that, for instance, in West Africa and in other, they had experience of Ebola quite recently. And, there have been lots of very successful programs around polio, right, which have involved the mobilization of contact tracers backed by laboratory tools, diagnostics. So I think those experiences may have made those health administrations, those governments, much more nimble and better equipped, really, than certainly than Britain and other modern Western industrialized countries.
Anything to add on your part?
No, I know very little about the African situation at the moment. Yeah.
I think I would probably think that one element in the weak answer that some European states had to the situation is a certain complacency, and you can relate that to the idea that global health was something that happened somewhere else, and we've been facing global health questions at home. Here's another question that I can pick up from while we wait for Jean-Paul to read. It's interesting. The moment you discuss global health, the global health expert disappears from the screen. I'm not into conspiracy theories, but anyway. So here's a question that's asked, and it refers to the classical historiography of epidemics. It's asked by Lutz Sauerteig from Durham. In the history of epidemics, from Ackerknecht to Richard Evans, people have often been interpreting answers along a line of more liberal or more authoritarian cultures, where like an answer that would be given by a German medical bacteriologist like Robert Koch would be authoritarian, and other answers would be more liberal. Can we use that to explain success or failure of measures in certain states, like for instance, the kind of disorganized British answer to COVID? Does it reflect a liberal tradition?
Well, I tend to say no, because for example, if you look at East Asia, Vietnam is very successful, and it's an authoritarian regime, and and they do have a kind of very tight social control. They use it in this pandemic prevention. But on the other hand, like Japan and Korea and Taiwan are sort of liberal democracy, and they are also doing relatively well. And so it's very difficult to find a kind of correspondence between the kind of political regime and the success or failure.
Yeah.
But I do think there are some, look at the kind of measure they took, maybe some part reflect the kind of the character of the regime. For example, like China, the method is kind of very much in the tradition of kind of mass mobilization, the mass screening, mass testing, and the kind of lockdown. But in Japan, that's the other way. They didn't have a kind of very strict lockdown.
Yeah.
But they are also okay. And so I think the kind of nuance, kind of difference need good comparative study to tease out the reason.
Yeah. So you seem to suggest that we're kind of beyond that classical framing of epidemic responses, and I think that's very illuminating. I'm picking up another question from the questions and answers, and this is one that is brought to us by Julie Powell from South Africa, and she is asking about the implications of the answer to COVID-19 for other conditions and their treatment, and in particular, she is referring to mental health. But I do think we can take that question a bit further and say, so how is it? So what's the answer to COVID-19 actually doing to health systems in the countries that respond to it? Speaking as historians. It is not so far from one of the points that you made in your introduction, Jean-Paul.
Yeah, well,
the traditional neglect of NCDs by WHO.
Yeah, well, actually, maybe I can make two comments on that. One is a direct echo of what I was saying about the massive gap in investments and concerns within global health institutions when it comes to the question of communicable versus non-communicable diseases. So, whether the COVID-19 epidemics might do anything to change the current balance, which is the fact that 95%, maybe more, of the resources are addressing communicable diseases, with the tuberculosis, malaria, and HIV as the big three, while everything else is left to outside the field itself, which it does for instance, mental health. It doesn't mean that there is no investment in issues of mental health care and so forth, but it means that the global health institutions are not doing that. So for instance, that in contrast to tuberculosis, for which we have had very, very significant investment in the chemotherapy, in the availability of drugs and so forth, you don't have anything comparable in mental health or cardiovascular disorders or so. I'm really not sure COVID will help change anything about that. First, because it's again pointing to the needs associated with infectious communicable diseases. And secondly, because my understanding of why is the investment gap so strong and so difficult to change has a lot to do with historical continuity. I mean, the fact that these have been the main targets for 50 years or 60 years of history of international health, so that they have been central in the construction of the institution, in the production of expertise, and they are still there. So in a sense, there are rationales to say, well, there are important problems, and it's difficult to build anything beside that.
Yeah, you know, what you say for me seems to really confirm a point that Mark made at the beginning, where he says we shouldn't be too sure that COVID is kind of the big game changer. It might well turn out that with a focus on the containment of infectious diseases, in 5 years we will see it as a blast from the past that reinforced the traditional imbalance in global health. Mark.
Yeah, so I mean, so I think actually it's very difficult to make this judgment, isn't it? I mean, I think I began by saying that it's not really the job of historians to sort of make predictions about the future or even offer particular lessons. But I think one clear lesson from the last 100 years of pandemics and epidemics is that we do tend to fall into this cycle of panic and neglect, right? So right now, as you alluded to at the beginning, Christoph, we're still in the panic stage of Rosenberg's famous, 3-act drama. Well, actually, we're past that. We're now in the recrimination and blame stage. But I mean, what usually happens is that pandemics end with a whimper, not a bang. And after they're over, the political priorities move on, the news agenda moves on. But I think there are many reasons why that might not be true in this case. And I think it goes to this question of mental health, but most particularly it goes to the way that the present generation, I'm talking about younger people in particular. So what has brought people out onto the streets? So I alluded to the way that, the right, people on the right and libertarians, what brought them out onto the streets was protesting the lockdown and the restriction of their civil liberties, and what they saw as a panic over, an unnecessary panic essentially over a health crisis that they didn't think was nearly as big a crisis and stop the economy. By contrast, what has brought many more people out on the streets is Black Lives Matter. And the connection, it's not clear quite the extent to which people are making the connection between the way that, racism is really an issue of mental health as much as a structural problem. And whether they're making the connection with the way that the lockdown is also, especially if you're poor and isolated, don't have many resources, has very much brought mental health onto the agenda, right? And this was already happening before COVID-19. So I think it's quite possible that trends that were happening before COVID-19 will be accelerated. It really depends on whether they continue to have that political momentum. And I think that's difficult to say.
Yeah, and it's not for us to say, as I share your hesitations as a historian to kind of, there's other experts for handling the glass bowl, it's not us. Yes, absolutely. We have time for one more short question because time is up and it's been a very lively discussion. And we have had surprisingly little technology turning on stage. We've mostly been speaking about the politics of answering and social technology, and what is very interesting. And looking at the history of epidemics, how much hope can we have for a technological solution like a therapy or a vaccine? Well, that's the question that was asked and I would like to hand it on. It comes from a student, and I think it should be asked.
That's a very good question. And I certainly put my faith in science in this respect. And, yesterday in the United Kingdom, we just saw how the Oxford Recovery Trial, which is an ongoing randomized placebo-controlled double-blind trial, has found strong evidence that an over-the-counter steroid reduces deaths from ventilated patients by a fifth and by patients on oxygen by a third, which is a tremendous advance. And I think it's really important to recognize that resulted from, what I call proper science. So there were all sorts of spurious claims not just by Donald Trump, but by some French scientists, I'm afraid to say, about you know, the efficacy of hydrochloroquine. So I think it's really important that you know, we let scientists and we invest in that sort of science. I think it's going to be very difficult, though, to get a vaccine. From what I know about the science, I think that, you know, we know that most vaccines fail, and that even those that are proved to be successful take at least 5 to 10 years, you know, to get to mass market. So I think that's a you know, something I wouldn't like to look in my crystal ball very much.
That's a sobering number,
Yeah.
5 to 10 years. We're wrapping up. Jean-Paul, Shangzhen, adding to this?
Well, just one thing, which because there was one question before, linking this question of vaccine versus therapy to the problem of affordability and cost. And I just want to point to one of the important difference between the two, which has to do with the nature of the market and the way the construction of the market is linked to evaluation and so. And because the markets for drugs are globalized, are a major scale, there is a much stronger entanglement and blending of clinical trials and market construction in the case of drugs than in the case of vaccine. And this may play some role in the future of these two putative biomedical, biotechnological responses to the pandemic.
Shangzhen?
Yes, I'm not expert on this issue, but I suspect that the drug, maybe the kind of treatment will come first, because people is using kind of old drug to treat new disease. And so there are sort of more venue to kind of open up a possibility of using some old drug to treat COVID-19. But by saying you need to develop it, you know, kind of through the whole process. So I guess, my hunch is that the drug will come first. But I'm not expert on that, so I cannot. So
we're meeting the limits of our expertise here, but that's how any good discussion, I think, should actually go. Let me thank you for your participation in the discussion, and everybody who attended for their very good question and their interest in this. And with that, I think we wait for more history to happen eagerly, and maybe a tiny bit afraid also. We'll see. Maybe we'll talk about it again in some time.
Yes, thank you. I'd love that. Thank you very much.
Bye-bye, everybody.
Thank you.